The topic of today's lecture is relapsing polychondritis. So let's get on with this lecture. Now we know that relapsing polychondritis is an uncommon disorder with an unknown cause. We do not know its exact incitatory event, what causes it, but we do know that it has an autoimmune component and sometimes an autoinflammatory component to it. Now, even though it is a very uncommon disorder, its study is important for doctors to not only know but to treat, because if it goes undiagnosed and then untreated, it can have life-threatening consequences for the patient. Now, there are two peculiar things that are associated with this disorder. One, it is usually found with other associated disorders, which are usually of rheumatoid origin and generally of autoimmune nature. So, we do not usually find this disorder in its separate form. We find it either as primary or as a secondary entity. So it is usually found associated with other diseases such as rheumatoid arthritis or systemic lupus erythematosus, and because symptoms sometimes overlap each other, its diagnosis sometimes goes undiagnosed. So that's why it is very vital for any doctor to understand not only its pathology but the symptomology and the progression of events that takes place. The other peculiar thing that is associated with this disorder is that its initial symptoms are non-specific and are antecedent to its defining symptoms. Or in other words, they appear before those symptoms which give it its primary or its distinctive diagnosis. For example, the saddle nose deformity, which are going to discuss further down the lecture. Now, this disease is the one where it primarily affects the cartilaginous structures in our body, and it does not affect all the cartilages which are found in our body. It usually affects only a select few sites in our body. Now, in this picture, you can easily see that this disease is affecting the ear of the patient. And the patient is showing not only inflammation of the cartilage underneath the skin, but is also showing some kind of expansion in the pinna of the ear. And this is very typical of a patient with relapsing polychondritis. Next, we're going to talk about which sites are more prone to having the attack of this disorder. The first one, like I mentioned before, is ear. The cartilage that is present in the ear is extremely prone to the attack of polychondritis. And because of its nature, its attacks keep on coming. That's why it's called the relapsing polychondritis. Their attacks sometimes are more frequent, sometimes they are more intense, but they keep on coming. And that's why it's called the relapsing polychondritis. Now, the other primary site which is affected is the nose. And when the cartilage of the nose is destroyed to such an extent, it forms a certain excavation over the nasal bridge, resulting in a typical deformity known as the saddle nose, as you can easily see in this picture. This patient has this deformity which looks like the saddle on a horse, and this deformity is very pathognomonic for relapsing polychondritis. The third site of importance is the laryngeotracheobronchial tree, or all the cartilages which are involved in the formation of the larynx, and the C cartilages which form the trachea and the major bronchi. Now, these can undergo the inflammation in this disorder, resulting in, first of all, cough. Cough can be non-productive, can result in pleuritic pain, among other symptoms. So the cartilages which are found in the joints are not usually affected, but those joints which are exclusively made up of cartilages, like the joints between the sternum and the ribs, these joints can show inflammation. But the three primary sites are always the ear, nose, and the laryngeotracheobronchial tree. Next, we're going to talk about its pathology. And its pathology can easily be understood if we look at the histology of a patient suffering with relapsing polychondritis. Now, here's a slide with such a patient. Now, as we know that this disorder results in the destruction of the cartilage, and that destruction usually happens via two main changes in the cartilage. One is the loss of the basophilic elements in the tissue, as you can easily see here in this histology, that all the basophilic elements of a normal cartilage are gone. The second is the infiltration of the eosinophilic components, which you can easily see here, that a lot of these infiltrates along with the chondrocytes are present in this site. The loss of the basophilic elements are the proteoglycans. Proteoglycans are structural proteins which give integrity to any structure. The most common proteoglycan which is found in the cartilages is the aggregan, and its loss can result in the loss of the structural integrity of the cartilage, which we usually see in the patient when the cartilage shows not only loss of its structural stiffness or hardness, but also its expansion due to the gravity. The infiltrates are usually of mononuclear kind. So because they are mononuclear, this leads to a more eosinophilic response. Now, these lesions can be both focal and can be diffuse, can occur at one site, can occur all over the cartilage, can occur in a symmetry, can occur asymmetrical. The pattern varies with every patient, but one thing remains constant, that the destruction of cartilage starts from the periphery and moves centrally inwards. Next, the pathogenesis of this disorder. Now, pathogenesis of it can easily be understood by the HLA-DR4. Now, we do not know the exact event, but we do know that those patients which present the human leukocyte antigen DR4 are more prone to having the relapsing chondritis than any other disorder. So if your patient is presenting this antigen and he or she also has some other rheumatoid disorder or lupus, it is worth evaluating for this disorder, because there is a 30% chance of this patient having relapsing polychondritis along with the rheumatoid disease. Now, whenever we have this kind of antigen, it results in an immune response. And in this disorder, the immune response is both humoral and cell mediated. Now, because of the humoral response, we get the secretion of certain autoantibodies, and because of the cell mediated response, we get the infiltration of mononuclear CD4 and CD8 cells, which I discussed earlier. Now, as for the humoral response, the autoantibodies which are secreted are usually of two kinds. The first is the anti-collagen type 2 antibody. Now, anti-collagen type 2 antibody is important because this collagen is the one which makes up the bulk of the cartilage which is found in the ear, nose, and in the bronchial tree. The other antibody that is formed is the anti-matrillin 1 antibody. Now, matrillin is also known as a cartilaginous matrix protein. So, this protein is found in the matrix of the cartilage. It is not found inside the chondrocyte, it is found outside, it is found along with the proteoglycans, and its destruction can lead to the destruction of the proteoglycans, leading to the destruction of the integrity of the cartilage. So both of these antibodies, along with the cell mediated response and the destruction of its integrity of the cartilage, results in frequent attacks of inflammation of the cartilages, which we term as relapsing polychondritis. Now, let's talk about the associated disorders which are usually found with the relapsing polychondritis. And these disorders are usually categorized into two. The first category is of the rheumatoid ones, those which show an autoimmune component to them. Now, these can be the systemic vasculitis, it can be rheumatoid arthritis, it can be systemic lupus erythematosus, it can be an overlapping mixed connective tissue disease, it can be spondyloarthritis. Now, all of these disorders are the ones which have a rheumatoid component to them, along with an autoimmune one. Now, the next category, which are usually associated with it, include both the Behçet's disease, along with polymyalgia rheumatica, the primary biliary cirrhosis, pulmonary fibrosis, Hashimoto thyroiditis, and the myelodysplastic syndrome. Now, these disorders do not have a rheumatoid component to them, but they do have an autoimmune component. Now, the reason that we study these associated diseases with this relapsing polychondritis is because the symptomology of all of these diseases overlap with each other, and polychondritis usually appears as a secondary disease to these primary disorders. About 30% or 1/3 of all relapsing polychondritis patients have some kind of a primary rheumatoid or non-rheumatoid autoimmune disorder. Now, because the symptomologies overlap, the diagnosis of a relapsing polychondritis can be often overlooked. And when it is overlooked, it can have very dire consequences for the patient. So you need to understand its symptomology. In order to understand the symptomology, you need to understand its pathology and the pathogenesis. And you need to understand how these symptoms overlap each other and why certain symptoms appear at certain sites and certain symptoms appear with other manifestations. Now, if you know the symptomology and the pathogenesis of the associated disease and the relapsing polychondritis, you can easily make a differential diagnosis where you can easily exclude those disorders whose symptomology does not match with the patient, and then you can make a simplified differential diagnosis where you can then further both confirm the diagnosis of either the primary polychondritis or secondary polychondritis. But in order to make a reliable differential diagnosis, you need to understand the symptomology and the pathogenesis of both the polychondritis and its associated disorders. So that's why it's very important to understand both of these. Next, we're going to study about the clinical manifestations or the symptomology or the progression of the symptoms which is usually found along with relapsing polychondritis. Now, the systemic inflammatory features which are usually found are fever, usually because it's an inflammatory disease. Patient present with sometimes low grade and unusually sometimes with a high grade fever. Patients also complain of fatigue. They also complain of weight loss. Now, this weight loss can be due to a secondary disease, can also be because of the polychondritis, because of the thinning and the destruction of the cartilages. Patient also sometimes complain of the hearing loss because the cartilages which are found in our ear, especially the middle ear, if they are inflamed, this can result in gradual loss of hearing. And because polychondritis usually appears as a unilateral disease, it can be easily distinguished with those diseases which have either bilateral hearing loss or those which have some kind of a sensory neural hearing loss. These patients also sometimes complain of nausea, and this nausea can be attributed to those patients which have some kind of a gastrointestinal manifestation. But as you can easily see, all of these symptoms are non-specific. None of these are specific enough to be labeled with the relapsing polychondritis or pathognomic enough to be considered to be only related to the polychondritis. And that's why these symptoms usually appear before the symptomologies, the severe symptomology of polychondritis. And that's why these symptoms sometimes get mixed up or can be overlooked when there's some kind other disease is associated with polychondritis. So that's why it's important to understand that if these non-specific symptoms are appearing with any rheumatoid disease, it is important to look for polychondritis too among the differential diagnosis. Next, we're going to study about the ear-related manifestations. Now, like I said, ear is one of the primary sites of infliction in this disorder, and because of this, patients usually complain of a unilateral pain in both the ear, the pinna of the ear, the external ear, and sometimes even the external auditory canal. And this can result in one, auricular chondritis. Auricular chondritis, or in other words, the inflammation of the cartilage which is found in the external pinna of the ear, is found in about 40 to 85% of all patients with polychondritis. And these symptoms should not be overlooked even if presented with an other disease. So one of the most primary symptoms of polychondritis is this, the auricular chondritis. Now, because of the inflammation, patients usually first complain of ear pain, which usually radiates towards the cheek, the eyes, and the jaw. This also results in tenderness, that area becomes so inflamed that it is painful to touch. Then it can result in swelling, because we know that it is an inflammatory disorder. So swelling of that area will happen. But how the pattern of swelling is appears is what constitutes in the symptomology of polychondritis, because like I said, it moves from the periphery to the central area, and sometimes even have some foci of normal tissue. So it is very important to understand the inflammation and the resulting edema and swelling that can result from it. Now, because the destruction of the cartilage inside the ear, the cartilage loses its structural integrity because of the loss of the proteoglycans. The chondrital sulfate is lost, the comb-like aggregan is lost, and because of this, the typical stiffness of the cartilage and the flexibility is totally lost. And because the pinna have a gravitational effect to them, the ears show a droopy appearance to them, and sometimes it can be very easily seen with a patient with polychondritis. Next, there can be an impaired hearing, like I discussed before. Patient can also have some kind of an inflamed internal auditory canal. Like I said, the inflammation of the ear is not only reserved to the external pinna. Sometimes the external auditory canal is also involved. Next, now because the external ear is involved and the cartilages which are present in the middle ear start to show inflammation, and because that inflammation can both compress or interact with the cochlea inside the ear, patient can suffer from vertigo. And vertigo is so important in the diagnosis of polychondritis that it is considered one of the main symptoms relating to the ear. Next, we have the ataxia. Now, ataxia is simply defined as the patient who have inability to walk, and this is all because of the either the structure or the sensory neural component of the ear manifestation. Next, we're going to talk about the nasal involvement. Now, nasal involvement is found in about 30% of all patients, and it is usually due to the severe inflammation and the resulting edema of the mucosa inside the nose, and this can result in a variety of symptoms. And these symptoms progress in a very systematic manner. First, we usually present it with nasal stiffness or stuffiness or a congested nose, that the patient is unable to inhale from the nose, either from the both nostrils or the one is more inflicted than the other. The normal physiological aspect of it, where one nostril is congested and other is free, and this rotate doesn't happen. Whole of the nose is congested and stuffed. Now this can result in epistaxis. Epistaxis is the bleeding from the nasal mucosa, and this is again due to the severe inflammation inside the nasal mucosa. And epistaxis in polychondritis is usually of anterior nature, that the bleeding comes from the little's area found in the anterior aspect of the nose. Then we have the rhinorrhea. Rhinorrhea is again due to inflammation, then the resulting edema, and that edema starts to leak out in the form of rhinorrhea or the discharge of fluid from the nose. This can result in the overall swelling of the nose. Now, not only the mucosa inside the nose is swollen, but the whole nose start to swell. And because now the symptoms have started to worsen. And because of this, the patient then shows further nasal inflammation, and this inflammation moves to a more posterior pharyngeal side and can even involve the upper area of the pharynx of the patient. Now, if this goes on for a long time without any treatment, the cartilage which is present in the interior aspect of the nose start to get destroyed, and because it is destroyed, it loses its integrity. A certain excavation start to appear, that the nose appears that it has fallen down, and that concavity looks like there's a saddle on a horse, and this saddle nose deformity is pathognomic for polychondritis, but it only appears in those cases where either the symptoms have gone unnoticed or the patient is having a chronic relapsing polychondritis with more severe and relapsing attacks of polychondritis. Next, we're going to talk about clinical manifestations relating to the joints. Now, we know that joints in our body are usually of three types: the synovial joints, which have cartilage on the end of the bones. We have the fibrous joints, which do not involve any kind of cartilage, and then we have the cartilaginous joints, which are usually found in the rib cage. Now, whenever a patient suffering from polychondritis presents to our doctor, the symptomology starts in a pattern that first of all, the patient complains of pain in the joint, and that pain or arthralgia can lead to other symptoms. That the arthralgia, if goes untreated, then worsens into arthritis, that is the full inflammation of that particular joint. Now, if that inflammation goes further to those joints which are the cartilaginous origin, then we can have the inflammation of those joints which connect the sternum with the ribs, and these costosternum joints, if inflamed, can produce not only tenderness at the anterior chest wall, but also quite pain for the patient. Now, this can further again worsen into the sternomandibular inflammation, that the inflammation between the ribs and the sternum has now worsened into the inflammation over the manubriae of the sternum. So the whole sternum along with the cartilaginous joints is now showing inflammation, and that inflammation is then presenting itself as pain, swelling, and redness. Now, if that goes untreated, it can even expand to the joints of the sternoclavicular area. And of all of these inflammations, if they are not treated, this can result in a very typical type of deformity known as pectum excavatum, or in other words, an excavated chest cavity, because the structural integrity of the cartilages is lost. The anterior chest wall first becomes flail or weak, and then starts to move inwards because of the repeated inspirations. The integrity is lost of the cartilages, and it starts to bend inward, resulting in this typical picture where the chest of the patient has now moved inward. And this is all because the initial symptoms were not diagnosed, were not treated, and this typical deformity has now taken place. And usually these kinds of deformities are permanent. They cannot be reversed. Next, we're going to talk about the ocular manifestations in polychondritis. Now, these manifestations can include conjunctivitis, that is, the conjunctiva of the eye is showing inflammation. This can result in a sticky eye. It can result in episcleritis and scleritis. Now, both of these are the inflammation of the sclera of the patient. The only difference is that in episcleritis, it's not painful, but the sclera is red. But in scleritis, it is not only red but also very painful. Now, if it goes untreated, it can then result in iritis, the inflammation of the iris, which then can move into the inflammation of the uvea of the eye, resulting in uveitis, which then can result in keratitis, that is the inflammation of the whole of the cornea. Now, if the keratitis is involved, it can even start to impair the vision of the patient, resulting in then the periorbital edema, that there's swelling starts to appear around the eye, and then that moves to proptosis, that is the eyelids starts to droop, and it even can result in optic neuritis. Now, ocular manifestations are important to study and to know their symptomology because they are visually threatening. Once inflammation of the uvea or keratitis has taken place along with maybe an optic neuritis, this can result in either partial or full blindness for the patient. And if it is only limited to the cornea, a corneal transplant can be arranged to restore the eyesight. But if the whole of the anterior chamber of the eye is involved, usually eyesight cannot be restored to such an extent that as it was before the onset of the disease. So the ocular manifestations must be very carefully observed and examined on the patient, as visually threatening conditions can very badly affect the quality of the life of the patient. Now, sometimes in ocular, but this is usually highly uncommon, we also see the extraocular muscle palsies resulting in the rapid or eye movement or the eyeball movement. This can result in retinal vasculitis or sometimes even in retinal vein occlusion. Now, these symptoms only appear when above symptomology goes totally untreated or totally unobserved, totally unexamined, and then patient suffers as blind. So, ocular manifestations are important. Their symptomology is important. Their progression is important. You need to know that, you need to catch it when it starts in order to give proper care and treatment for your patient. Next, we're going to talk about the respiratory or the laryngotracheobronchial involvement in polychondritis. Now, it is important because we know that both the larynx, trachea, and the main bronchi are mainly composed of cartilages. Especially the trachea and the bronchi are composed of the C rings, which are totally made up of cartilages. And in polychondritis, whenever the laryngeal bronchial tree is involved, it again moves in a symptomology that is from mild to moderate to severe if it goes undiagnosed and untreated. So usually we see a patient with hoarseness, and hoarseness is because of the inflammation of the tracheal cartilages. Because the inflammation, the patient is unable to produce high-pitched sounds. resulting in the hoarseness of the sound of patient's voice. Now, then patients also complain of non-productive cough. Now, because only the trachea and the main bronchioles are involved, and sometimes only the larynx, there is no exudative element inside the trachea, resulting in cough that is non-productive. Then it can lead to tenderness. Now, because of the inflammation, it can result in tenderness that the chest becomes painful to touch. Now, if these symptoms go undiagnosed, it can then further result in the mucosal edema of the pleura, which can then result into the strictures, and these strictures can then result in stridor. And this stridor, when it starts to show, and these strictures can cause the patient to lose its ability to inspirate properly, resulting in some patients tracheostomy. In order to improve the oxygen saturation of the patient, tracheostomy is usually performed if these symptoms worsen to such a degree that strictures and stridor starts to appear. So tracheostomy makes sure that the patient is having enough air and enough oxygen. Now, if the patient is even then has more undiagnosis, or the symptoms are overlooked, this can result in airway obstruction in either one of the main bronchi or the small bronchi, resulting in obstruction of either the lobes or either the one whole side of the chest. This can then further get severe as tracheobronchomalacia, or that is the tracheobronchial tree becomes inflamed to a degree that the air inflow is totally obstructed. Now, this then further can result in pneumonia, and this pneumonia can give way to respiratory insufficiency, or in other words, the patient slowly becomes unable to breathe. Now, if the tracheostomy is not performed at the appropriate time, the patient can have cardiopulmonary arrest. So this symptomology has to be looked, has to be observed. Now, there is a saying that eyes cannot see what the mind doesn't know. You need to know these clinical manifestations, you need to know these symptomologies in order to observe them, in order to recognize them. If you do not know them, you cannot see them, you cannot observe them. So in turn, your patient goes undiagnosed, resulting in either the lethal consequences for the patient or worse quality of life for the patient. Next, we're going to talk about the cardiac involvement. Now, the cardiac involvement in polychondritis stems from the valvular insufficiency, because we know that cartilages are present in the valves, which are found all over the heart and protect one chamber from another. So if blood flows from one chamber to another, it is because of the opening and the closing of those valves. And now, because those valves have started to undergo inflammation, this has resulted in valvular insufficiency, resulting in symptoms such as valvular regurgitation. Because now the valves are not closing well enough, the blood can regurgitate back into its chamber, resulting in regurgitation. It can result in aortic regurgitation, that the whole blood then moves backward into the aorta instead of moving towards. It can result in pericarditis, because we know that pericardium mainly comprises of fibrous tissue. So that tissue can also show some kind of inflammation. It can also result in myocarditis. It can result in coronary vasculitis, and coronary vasculitis only appears when both the pericardium and myocardium are inflamed to such a degree that the vasculature inside the heart, inside the myocardium, is inflamed too, resulting in coronary insufficiency, which can lead to a myocardial infarction or myocardial ischemia. Another symptom that might appear are the conduction abnormalities. Now, these conduction abnormalities are due again because the myocardium contains the fibers which conduct the electrical signals from the SA node to the AV node and to the Purkinje fibers and the whole conduction pathway. Now, if the myocardium is inflamed, the conduction pathways are compromised, resulting in arrhythmias and conduction abnormalities. Sometimes, if all of these symptoms go unobserved, undiagnosed, aneurysms can appear. And aneurysms are bulging out of the vessels where the walls have started to thin, and if the pressures keep on building, they can even rupture. And a rupture of an aneurysm in aorta, in heart, or even in brain can have dire consequences for the patient. Next, we're going to talk about the renal manifestations. And renal manifestations are due to the deposition of certain immune complexes and complements on the tubules of the nephrons. Now, because of these depositions, we usually see such symptoms or such histological patterns such as mesangial expansion, which is again due to the deposition of these immunocomplexes. We see segmental necrotizing glomerulonephritis, that the tubules of the nephrons start to show necrosis. The cells start to die out in a segmental way, resulting in the loss of the nephron's ability to filter the blood and to make urine. This can again lead into the tubulointerstitial disease. Now, not only the segments are involved, but the whole tube or the whole interstitium of the nephron start to get involved. This results in further renal insufficiency for the patient. And when this deposition of both the immune complexes and the complements gets so intense, so severe, it can result in a typical disease known as IgA nephropathy, sometimes also known as the Burgess disease. And this must be taken very seriously. Next, we're going to talk about the skin involvement in polychondritis. Now, skin involvement starts with purpura because we know that it is due to the inflammation and autoimmunity that is found inside the blood. Now, because of this autoimmunity, purpura or bluish spots or reddish purplish spots start to appear all over the body. Now, this can lead into an erythema nodosum, where nodules of purplish reddish color start to appear. It can even result in erythema multiforme, where the patches of well demarcated rashes start to appear, which look like urticaria, only it appears over all of the body. We get other symptoms such as angioedema, which is described as the accumulation of the fluid or edema beneath the skin. And the usual sites of the edema is face, chest, the respiratory system. Angioedema can appear. It can further lead to urticaria, that is the formation of the hives due to an allergic response to either the pro-inflammatory chemokines or the autoantibodies. It can then further even result in livedo reticularis. Now, livedo reticularis is a condition where the discoloration of the skin appears in a mottled kind of a way, with the patches of both reddish and purplish coloration start to appear in a lace-like pattern. And this is again due to the inflammation of the underlying vasculature, which is found subdermally. Another presentation is the panniculitis, or the formation of painful nodules beneath the skin, which can then involve even the skin which is beneath which it lies, resulting in a typical picture of panniculitis. Now, these skin involvements are again can be confused with another disease such as scleroderma, but again you need to know the symptomologies and the pathogenesis of each clinical manifestation. Next, we're going to talk about laboratory findings in a patient with relapsing polychondritis. And usually patients with such a disease present a very typical picture when a complete blood count is performed on their blood. So usually we see leukocytosis, that there is an increased amount of white blood cells. We see normochromic anemia, that there is reduced count of RBCs, but those RBCs have normal concentration of hemoglobin. We also see eosinophilia, that eosinophils are increased, and that is usually in response to the inflammatory chemokines. We also see elevated ESR, indicating that some kind of inflammation is taking place. We also see elevated C-reactive protein, solidifying our suspicion that inflammation is taking place inside the body. Then we have increased levels of type 2 collagen autoantibodies. Now, these type 2 collagen autoantibodies are specific to relapsing polychondritis. So if these antibodies are found in a patient, the suspicion that relapsing polychondritis is present is increased even more. And this can be confirmed by doing some other tests and some other laboratory findings, which I will discuss further. Other things that we also see in the blood are circulating immune complexes. Now, these immune complexes can be of a variety of origin and cannot be predicted. The only thing we know that these immune complexes result from the destruction of the cartilages in polychondritis. We also see elevated gamma globulins, that not only certain specific antibodies are increased, but gamma globulins as a whole increase too. We also see some antineutrophil cytoplasmic or antibodies. Now, these ANC antibodies can be both C-ANCA, can be both P-ANCA, that is, they can be perinuclear, they can be cytoplasmic. Both of these antibodies can give a solid presentation, a solid suspicion that this patient is having polychondritis or some kind of other autoimmune disease with a vasculitis component to it. We also sometimes and very rarely see myeloperoxidase ANCA, and sometimes, though it is only found in only a handful of patients, but proteinase 3 ANC can also be found in patients with polychondritis. Next, we're going to talk about its diagnosis. Now, we studied what kind of laboratory findings in blood we can see. But in order to diagnose the patient or to confirm the diagnosis of a relapsing polychondritis, we usually perform biopsy. Now this biopsy has to be full length. The whole length of the dermis has to be involved, along with at least the half portion of the cartilage. Now whenever we see biopsy being done on cartilage, the whole of the cartilage, if biopsied properly, can give us a very typical histological picture where there is low basophilic count and increased eosinophilic elements, again proving that this patient is having polychondritis. Next, we're going to talk about the diagnostic criteria. Now, like I said before, polychondritis has a variety of symptoms and a variety of symptomologies, all of them progressing in a very specific manners. When you have so much clinical manifestations, diagnosing such a disease, especially in relation to other rheumatoid or autoimmune diseases, can be difficult. So a diagnostic criteria has been created. It is called the McAdams diagnostic criteria for relapsing polychondritis, and it states that patient must have recurrent chondritis of both the auricles, that the inflammation of the cartilage of the both ears must take place, and it should be recurrent. It doesn't matter if it's more frequent or more severe, but it should be recurrent. Then there must be a non-erosive inflammatory arthritis. Now it is important because if it's of erosive nature, symptomology or the diagnosis can point towards rheumatoid arthritis. So in polychondritis, the arthritis is of non-erosive nature. Next, there must be chondritis of the nasal cartilage, that there must be some inflammation of the nasal cartilage. There must also be an inflammation of the ocular structures. Now, this can be either conjunctivitis or keratitis or uveitis, but some kind of ocular involvement must be there. Then it must also have the chondritis of either the laryngeal or the tracheal cartilages. Now, it is important that this must be involved, only the larynx or the whole of the tree. But this system must be involved, must be inflamed. Now, if all of these are involved and all of these symptoms are present in a patient, we can easily say that this patient is suffering from relapsing polychondritis. Another diagnostic criteria that we usually see is either the cochlear damage or vestibular damage. Now this is related to the chondritis of the auricles and the sensorineural loss and vertigo that the patients sometimes complain of. When all these 6 symptoms are present in a patient, we can easily say that this patient, along with the confirmation from biopsy and laboratory findings, that this patient is suffering from relapsing polychondritis. Next, we're going to talk about the diagnostic tests. Now, these diagnostic tests can be computed tomography. Now, CT scans are done in order to visualize that how much of the cartilaginous destruction has taken place. We can also perform MRI. MRI are again performed in those patients where inflammation is extensive and there is much edema present in those patients. So in order to get a clearer picture, we usually perform a T1 or a T2 weighted MRI scan. We can also perform bronchoscopy in patient. Now, bronchoscopy is an endoscopic procedure where we directly visualize the larynx, the trachea, and the main bronchi of the patient. And this can give us a direct visualization if the patient is suffering from the inflammation of the cartilages of these laryngobronchial tree. We can also perform pulmonary function test. Now, because of this inflammation, the airflow is usually obstructed, and because of this obstruction, the pulmonary function test start to reduce, especially the vital capacity of the patient is reduced drastically. So pulmonary function tests can give us a good idea that how much damage has taken place in the patient with respiratory manifestations. Then we can perform X-ray as usual. A normal chest X-ray can give a variety of information from the mediastinum to the lung spaces to the involvement of the heart to the involvement of the ribs, the sternum, and even the larynx and the vocal cords. So a plain X-ray can also be very beneficial. Next, we have electrocardiography and echocardiography. Both of these are done in those patients which show more of cardiac involvement and cardiac manifestations, because echocardiography can detect abnormalities in conduction pathways, and echocardiography can detect structural abnormalities in heart with ease. Next, we're going to talk about differential diagnosis. Now, this is important because, like I said, relapsing polychondritis symptoms overlap with a variety of other diseases. Now, in order to distinguish them, those diseases which can have a mixed symptomologies usually are, we have the granulomatosis polyangiitis or the Wagner's disease. Now, Wagner's disease can be distinguished from polychondritis by the pattern by which it attacks, because the pattern of attack of cartilage is different in polychondritis and it is different in the Wagner's granulomatosis. Then we have the Cogan syndrome. Cogan syndrome can have symptoms similar to polychondritis, only that there is no respiratory involvement. So if your patient is having respiratory involvement, Cogan syndrome can easily be excluded. Then we have the reactive arthritis, which again can present the arthritic or the joint involvement symptomology that we saw earlier. But in reactive arthritis, there is no ear or nose involvement. So reactive arthritis can be differentiated by the involvement of both nose and the ear. If they are involved, reactive arthritis can be excluded. Then we have the rheumatoid arthritis. Rheumatoid arthritis usually results in one symmetrical and erosive pattern of arthritis, while in polychondritis it is asymmetrical and non-erosive arthritis. Other diseases which can mimic the symptomology is the bacterial infection of the pinna or the external ear. Now, because of the bacterial infection, especially if it's hidden, can result in the inflammation and the swelling of the whole of the ear, giving the appearance of a chondritis or auricular chondritis. And it can be easily differentiated by having the symptomology where the fever is more intense and the patient has bacterial sensitivity and cultures which can be performed on his or her blood. There can also be trauma. Trauma can also result in inflammation of either the one or both the ears or the eyes, and it can be easily be ruled out by taking a good history. Other is a cocaine, which is adulterated with a specific substance known as levamisole. And levamisole is causes thinning of the cartilage which is present inside the nose. So for those patients which have a cocaine addiction and perform snorting, their nasal septum and nasal cartilage shows thinning in a very specific pattern. So these patients can be also easily distinguished from normal polychondritis. Next, we're going to talk about the treatment. Now, the treatment of relapsing polychondritis is simple. What we do is that we have to suppress the inflammatory response of the body. And in order to suppress the inflammatory response of the body, we start with glucocorticoids. And the glucocorticoid of choice is prednisone, which is started at about 40 to 60 milligram per day as a loading dose, and then can move on to about 5 to 10 milligram per day as maintenance dose. And for some patient, even the maintenance dose is not required. Now, for some patient, the autoinflammatory component is less and autoimmune component is more. For such patients, we give immunosuppressive drugs, because for those patients, glucocorticoid therapy's immunosuppressive effect is not enough, because especially glucocorticoids have more of an anti-inflammatory effect. So in order to suppress the immunity of those patients, we give the immunosuppressive drugs, and they can be as a thioprin, it can be cyclophosphamide, and it even can be cyclosporin. All of these drugs can be given to the patient, but they must be given with care. You need to perform both the liver function test and the renal function test in these patients, because all of these immunosuppressive drugs are not only nephrotoxic but also very hepatotoxic. Next, we can also give intraocular glucocorticoids. Sometimes even systemic glucocorticoid therapy or immunosuppressive therapy, when given intravenously, is not enough. So in order to combat those patients which show more of the ocular manifestations, we can give intraocular injections of glucocorticoids, and they can reduce the inflammatory and the immune response locally inside the eye. Next, we have the tumor necrosis factor antagonist, for example, infliximab. This monoclonal antibody can be given to suppress the tumor necrosis factor. So in fact, the inflammation cascade is inhibited and the patient's inflammation goes down. We can also give rituximab. Rituximab is a CD20 inhibitor. So it helps in the suppression of the cell-mediated immune response. We can also give the tocilizumab. Now, tocilizumab is a humanized monoclonal antibody, and this is given as an antagonist for the interleukin 6 receptors. So if interleukin 6 is inhibited, the effect of inflammation cascade doesn't move forward, and the inflammation is inhibited and suppressed. Now, for some patients, in order to treat them, simply giving drugs is not enough. For some patients with major cardiac involvement, heart valve replacement is always an option. For those whose valve has given way, are either totally destroyed or are not functioning properly, their valves can be replaced in a heart valve replacement operation. We can also perform repair of an aortic aneurysm. Now, if the patient is showing signs of an aortic aneurysm in its cardiac involvement, a repair of the aneurysm can be performed and the integrity of the aorta can be maintained. We can also perform tracheostomy, and tracheostomy is performed in those patients which have severe respiratory symptoms, as so much that the air inflow through the larynx is totally obstructed and the airflow through the trachea and the major bronchioles is, because of inflammation, narrowed and reduced. So the tracheostomy is performed in order to maintain both the air inflow and outflow and the oxygen saturation of the blood in those patients. We can also perform stents. Now, stents is given in only those patients whose coronary vasculature or circulation is compromised. So, in order to recirculate the coronary circulation, to recirculate the blood, stents are given which dilate the vessel and give way to a better blood circulation in heart. Again, these methods, these surgeries are performed in those patients with severe and massive cardiac involvement of polychondritis. So this was the lecture on relapsing polychondritis, where we discussed not only what relapsing polychondritis is, we discussed its pathology, its pathogenesis, we discussed its various clinical manifestations from the ocular to skin to joint to respiratory. We also learned about the associated diseases and the differential diagnosis, and why learning about these is very important for any aspiring doctor. We also learned about its treatment, and we also learned which treatment can be given as systemic therapy and which surgeries can be performed on which patient. So thank you so much for watching sqadia.com.